Welcome back to the Physio Matters podcast, this time for a feature-length edition exclusive to our seldom-used YouTube page. Session 16 with Greg Lehman has already attracted just under 20,000 full listens since its launch 2 weeks ago. And in keeping with the critical thinking ethos that we stand by, it has divided opinion. So, for the first time, I can present our first broadcast response to a podcast. This is by Brad Neal from Pure Sports Medicine. Well, welcome to a special edition of the Physio Matters podcast. Brad, would you like to introduce yourself first and foremost for the listeners?
Of course. So my name is Brad Neal. I'm a physiotherapist and research lead in private practice at Pure Sports Medicine in London, and also a current PhD candidate at Queen Mary University, looking at running biomechanics and the interaction of the hip and the foot in relation to patellofemoral pain.
Fantastic. And your name came up in my chat with Greg Lehman recently for session 16, and you approached me saying you might have a few points that might be worth raising in defence of biomechanics to some extent. So what would you like to start with?
I think it's fair to say that Greg's podcast was an excellent listen, and it raised a lot of interesting points, and something Greg and I have always sort of discussed when we've interacted personally over the years is that we're probably not that different, and that's probably why we sort of question and challenge one another on a regular basis. But there were a couple of key points that sort of made my ears prick and made me think, that's not quite the way I think about that, which is obviously not a problem. Everyone reads things through slightly differently. But I thought it would be worth raising a couple of key points just to kind of show the other side of the coin, which I suspect will probably find us arriving at a similar endpoint, perhaps just taking a slightly different journey.
Okay, brilliant. No, that sounds great. What typically first pricked your ears up then of our chat?
The first thought that really sort of made my eyes widen as I was listening on the train on my way into clinic last week was the discussion around risk factors, and particularly risk factors from a biomechanics standpoint, which is something Greg and I discuss fairly regularly, and I hope I don't misquote him based on what he said within the podcast, but I know certainly on Twitter Greg and I have discussed the fact that he doesn't consider things like hip adduction and hip internal rotation to be risk factors for pathology. Specifically, we'll think about patellofemoral pain because that's where we are, and that's definitely something that I disagree with and think that perhaps the research tells us a different story to what Greg's thoughts sometimes tell us. So stop me if I go on for too long, or if you want to...
Not at all, no. I think the listeners would much rather hear from you, Brad, so you crack on, that's fine.
That's very generous. But I think it's initially important that we first recognise that research to identify risk factors, what we call prospective research, is initially very, very difficult to perform. And that's why there is a dearth of prospective research in lots of different pathologies. And in terms of patellofemoral pain, thinking about running, knowing the topic for a systematic review we're writing at the moment, there are only 3 prospective studies that look at a running population in relation to patellofemoral pain. So there's a very nice study from, I believe, Clinical Biomechanics, I could be wrong, from Brian Noren's group in the US, looking at female cross-country runners, which shows a very strong evidence for the fact that hip adduction is a risk factor for patellofemoral pain. And then there's also a very nice study in the American Journal of Sports Medicine from Michelle Bolling and her group in the US, looking at a similar topic using a jump land as opposed to running. And they found that hip internal rotation as opposed to hip adduction is a risk factor, which you can present the argument, well, one study has found X and the other study has found Y, so we're seeing 2 different things, so maybe neither of them matter.
Okay.
And I personally think that that's not quite accurate. And what we need to know, and what we're hopefully on the way to understanding, but will take time, is that risk is never a singular variable. Many different factors, or what we call covariates, come together to put a person at risk of a pathology. And it's absolutely correct that hip adduction or internal rotation in isolation is unlikely to be a risk factor for pathology. But if you look at those 2 studies, they're almost looking at 2 different things. The Brian Noren study, as I said, is only female subjects, only looking at cross-country runners. So there's a very different the sample population to the Bolling study, which was done in a military setting, sort of 1,300 or more participants, with a very strong slant towards the male population. So whilst they're both prospective studies looking at patellofemoral pain, they're trying to show us risk in individual populations. And I think that's the big difference, that sometimes we're not quick enough to explain or certainly reason through when we look at these things. So that was something that definitely made my ears prick. And I don't consider those things to be irrelevant variables because different papers show different things. I think what we really need to understand is the interaction of these variables. And Greg quite nicely made the point that he could be perhaps classed as the enemy because he doesn't do research anymore and he's just a clinician now. And again, there's absolutely nothing wrong with that. But for those of you that understand research methodology, we know that prospective studies are hard, and we know that looking at the interaction and the subgrouping of all these covariates is very challenging to do. And we look at sample size, we look at power, and we want to make sure that we've got enough people in our study in order to show a statistically different change in different groups. And if we start to take all of these sort of tiny clinical subgroups that appear of someone with hip adduction 2 standard deviations above the mean, also wearing a certain type of footwear, also being overweight, also having an altered pain pressure threshold. As an example, we know that all of these variables are going to interact, but it's very, very challenging for us to study them. And I think what we have to accept with prospective studies is they do to a point show us that that's the regression to the mean. And whilst we don't necessarily see a completely homogeneous population in clinic, we've got to take that and apply it to the evidence and apply it to our patients. And that's the challenge. The research can only ever show us so much. There's no substitute for good quality clinical reasoning. And that's probably why 5 different clinicians can be effective with 5 different approaches and come to the same endpoint. And it's, for me, what fascinates me is understanding the processing and the reasoning and seeing where people end up with their patients.
No, absolutely. And if we were to say, then if these bits of data are stratified and certain biomechanical variables are, say, combined, from my understanding, you feel that kinetic values correlate with current patellofemoral pain syndrome and the likelihood of developing it. Have I got that right?
To a point, that's going on to what would have been my second point, which was the discussions around the systematic review that our group published at the back end of last year.
So you don't mind me dragging you into that now, then, or?
No, of course not. Of course not. Which to a point frames the discussion nicely. But we published a systematic review that took a long time to complete. It was a 3-year project in conjunction with La Trobe University in Melbourne, looking at the interaction of foot posture variables in relation to injury development. Over here, myself, Ian Griffiths and Christian Barton took on the static studies, so things that look at navicular drop, the foot posture index, etc., etc.
Yeah.
The guys in La Trobe took on the dynamic variables, so things like plantar pressures, 3D kinematic analysis, these types of things, to look to see what was a risk factor for injury. And we always had the premise that the work we were doing over here was potentially going to be more clinically relevant, because in clinic we can do things like navicular drop, we can use the FPI, we can look at calcaneal index, whereas 3D kinematics, plantar pressures, not that many clinicians have that capability within their clinics. So we were excited about that, and we pride ourselves on the clinical applicability of what we do, because we're all clinical academics. We are heavily immersed in the world of research, but we all still treat patients, lots of patients. So when our review was published, a few people came along and said that there was no clinical relevance of our work, which did put our noses out of joint a little bit, perhaps unnecessarily so. Everyone gets upset from time to time. It's difficult to upset me. I'm a pretty affable, easygoing guy. But when a piece of work that I've written that took 2.5 years and is being highly accessed in an open access podiatric journal, to be told that it's of no clinical relevance, it did get up my nose a little bit. And the discussion surrounding it was that if you look at the navicular drop findings, which showed strong evidence that navicular drop is a risk factor for medial tibial stress syndrome, people were saying, well, if you look at the data sets, and on one hand, it's nice to see people going through a results section with such rigor, which is, the methods and the results of a paper are the 2 most important parts to read, and
of course,
2 most important parts that are missed by most people. On one part, it was nice to see people going through that with a fine-tooth comb, but the argument for the medial tibial stress syndrome data was that often the difference between the groups was around 1 millimetre. looking at the mean average. Now, the standard deviation is important because that shows you the width of the sample. And often in the symptomatic groups, the standard deviation was larger, which shows us that there's perhaps a more varied navicular drop, as an example, value within that figure. But something that I'm looking at more and more, and I think something that it's fair to say that we should all probably look at a little bit more, is it only takes a small amount of kinematic change to have a fairly significant kinetic effect. And by kinetic, we're talking about the forces acting on the foot, the limb, etc., etc. Yeah. And it's difficult to suggest that within that paper because we are only looking at static measures. There's no discussion around kinetics at all.
Yeah.
Whereas in the dynamic paper, there is some data from an author called Yanni Fiss, who looked at plantar pressure measures in terms of the development of patellofemoral pain. And we know that increased loading under the second and third met and a higher velocity of loading, so time to peak force under the lateral heel, is also shown to be predictive of patellofemoral pain. So something I'm going to look at more and more in my work is the interaction of kinematics relative to forces and also EMG, and trying to see what goes on when we see fairly finite kinematic changes, but what we think to be fairly significant kinetic changes. And there's a really nice paper by Dorsey Williams and Irene Davis that look at the kinematic and the kinetic effect of orthoses. And we know that you can have absolutely no kinematic change with the insertion of an orthosis, but still have some fairly significant kinetic changes. So I think that's a variable that's relevant, and just because we don't see masses of kinematic change, that doesn't mean it's not clinically relevant. Now, it is challenging with static measures because what we know is that the continuous data, so data that's measured in an ordinal scale from 0 degrees to 10 degrees as an example, we know that that's more sensitive. We pick more things up there.
Yeah.
If you look at the dichotomous data, which is where there's a cutoff, so plus or minus 10 degrees, the risk ratios that we calculated for the papers that presented that data in that fashion was fairly insignificant. The risk ratios were very small, just the other side of 1, which is essentially chance or dumb luck. So in an ideal world, it would be lovely to have dichotomous measures, yes or no, pass or fail, plus or minus, but we know that the human body is too complex for that. We've got this wonderful nervous system that makes us do all of these individual things. We've got different variances in our skeletal anatomy, our muscular anatomy. So continuous measures are a lot more sensitive, and that's where the navicular drop risk ratios come from. So that was something else that definitely made my ears prick up. And I think perhaps the results have been sort of misinterpreted to a point. And we felt quite strongly that we had made, there's a whole section in the paper called clinical implications. And we suggested that whilst the evidence is strong, the effect is small. So consider it as a part of a multifactorial risk assessment. It's not the be all and end all, the only variable. We felt like we made that point quite strongly. But in terms of the minimal kinematic change, I don't think that means that our findings are insignificant and that there isn't a kinematic risk with regards to MTSS in this case, or patellofemoral pain from the Bolling paper. Just that we need to look at how that kinematic variable interacts with everything else. It all comes back to these covariates and subgroups. And you probably will find people with a high level of navicular drop who don't have increased forces at foot level and knee level, but then you probably find people with increased navicular drop that do, and vice versa. And Greg makes this point quite often. If you look at a study where you pull off the people that become symptomatic and compare them to the people that aren't symptomatic, if there's a difference, there must be people in that asymptomatic group moving the same. And I don't disagree. I think that's completely relevant. But the interaction of all the other covariates is what we need to know. And this is where prospective research needs to go, in my opinion.
No, I can completely understand that. It's more my style, if I'm honest, to sort of suggest that everything is relevant. It's just trying to work out which is more relevant at which moment in time, which is a damn minefield, and we'll keep chasing that dream, I guess. But, stratification and individualization are to some extent the thorns in the side of many different types of research. So I completely agree. Clinical reasoning is what we need to lean on, and I know you're a big advocate of that, so I do appreciate it. But if we say, Let's just use an example then. Say hip adduction coupled with hip internal rotation and maybe a certain tailor angle at foot strike come to correlate strongly with symptoms at the patellofemoral joint. Let's say we'll fast forward in a few years and we come to that conclusion, potentially due with thanks to your research, etc. How can we reliably and consistently measure something like that in all of our clinics for our Joe Bloggs runners to make it a priority almost, or one of the priorities we have when we make assessments?
That's a lovely question, and I think to sort of reverse a little bit before we sort of get on to picking that up clinically.
Yep.
My stance on hip adduction, and you mentioned correlation, which is nice because there is obviously a big difference between correlation and causation. Is it chicken and egg, etc.? But again, the way I interpret data that looks at correlation, I don't look at it on its own. I look at it in relation to the causative data. And if the causative data tells the same message as the data that just looks at correlation, I think you can infer causation from that. Because if someone has, let's say, 2 standard deviations above the mean of hip adduction and they go on to develop patellofemoral pain, if we then look at a group of people who already have patellofemoral pain and we see this increased hip adduction, for me that's the same message. And that's the way I interpret that data. And then when you add in the studies that show if you change hip adduction, you change symptoms, that's a much stronger message around causation. Somewhere I think data that looks at correlation can be really useful is when we think about adaptations to pain. If you look at all of Paul Hodge's great work and all of the lovely work done by the neuroscientists that show us that we know that people do different things when they're in pain to when they're not, if the correlation data is completely different to the causative data, that to me is showing us our adaptations to pain. So I don't look at necessarily making a change to a movement that's adaptive, because if you tackle pain, then often the adaptive movement will reverse and go back the other way. But in terms of picking it up in clinic, there's a couple of nice papers, one in Physical Therapy and Sport, the author's name escapes me, Watman, I think, in 2010, looking at if jump landing, single leg squat, and a few other measures are predictive of the same kinematics in a running population. And the ICC values are pretty strong, particularly for jump landing. So you can pick up hip adduction very nicely in a jump landing, and you can, based on that one paper, infer that if someone does it in a jump land, which we should all to some extent be able to look at during a clinical analysis, you can then infer that that is likely to happen when someone gets onto a treadmill or gets out onto the road as well. And there's a paper that was published just a couple of weeks ago, which I've just cited in the systematic review I mentioned, which looks at the reliability of 2D gait analysis, so just with a standard video camera or UberSense, iPad, whatever, in comparison to 3D kinematic analysis. And the strongest variable to be reliably picked up in a 2D analysis relative to a 3D analysis was hip adduction. So again, hopefully a treadmill, a stretch of ground where someone can run, and an iPhone, an iPad, a camera, etc. Hopefully all of these things are becoming more and more accessible to clinicians. And if we know that we can reliably pick up a variable 2D compared to what we know in research in 3D terms, that's a really powerful message. And it frustrates me when authors don't cite their reliability, because let's take the Brian Noren paper as an example. I'm fortunate enough to have interacted with Brian Noren a couple of times, and he's got a phenomenal brain in his head, and his scientific rigor is second to none. And he always cites his reliability. They've developed a lovely placement device for their kinematic markers, and he will hold his hands up and say the hardest thing to measure reliably is hip internal rotation. And that's often why we don't see differences. So we know that rotation's tough to pick up. We know it's difficult to measure in a reliable fashion. So if we can have this strong message around hip adduction, that's a much more clinically appropriate message, because can my eyes pick up internal rotation in 2D analysis? Absolutely not. Can I pick it up in my lab with 3D kinematics? We can. We're looking at our reliability at the moment for our running work, and internal rotation again is the most unreliable measure that we do. But our ICCs between one another and individually are still sort of 0.6, 0.7, which is good. But that's the strong clinical message for me is really sort of building around hip adduction, which is something that perhaps sort of scientists like Greg don't agree with. But I like to think I could defend it quite nicely.
And you do defend it very well. In terms of the nature of the hip abduction, where you say you can't necessarily eyeball internal rotation, do you feel that the degrees of significance are eyeballable and measurable in that sense for hip adduction during a running gait analysis?
I think they are. I think if you use something like UberSense or Coach's Eye or one of the sort of excellent freely available minimal cost movement analysis platforms, just be drawing a couple of simple lines, I think you can. I would consider, and I can't tell you too much because we're not allowed to talk about stuff before we submit it for peer review because it's not accepted science yet, but my clinical suggestion is that an increase of hip adduction of 5 degrees is clinically relevant, and I think you can pick that up with 2D analysis, and it's backed up by that paper from the International Journal of Sports Medicine, which was published a couple of weeks ago. For anyone that's interested, I've got my inbox up here. I'll just
we'll soon circulate that for sure. No, that sounds interesting.
It's concurrent validity and reliability of 2D kinematic analysis of frontal plane motion during running. And the lead author is someone called Maycutt. That was published a couple of weeks ago.
Cool. And I'm happy to be corrected here because I am punching even further above my weight than usual. But I couldn't a runner's kinetics be influenced by a wide variety of factors and therefore interventions, if you're trying to say change that? So do we actually land anywhere differently when it comes to treatment?
I think we do. I think the question is whether doing different interventions leads to the same end, and that's definitely something that Greg alluded to. My personal stance with regards to running, and this is based on our own data and based on this systematic review that we're submitting shortly, and you can pick it up if you read the papers. There's very good evidence from a couple of very nice observational studies, again from Brian Noren and another very good colleague of mine called Richard Willey at the University of Carolina, looking at gait re-education using visual or verbal feedback in order to change a runner's gait. And what we know changes significantly post-intervention is hip adduction. So it's a recurring theme, and that is coupled with a significant change in symptoms and function. Now, in a running population, there's 2 studies. Jennifer Earl Bonham is one, and I think KM Bashi is the other, looking at strengthening exercise in a running population. And what we know with those 2 studies, and if you go on my ResearchGate profile, there's a presentation of mine from the Danish Sports Medicine Congress in January of this year, which has some of this data in it, which is published on ResearchGate as an abstract, so you can have a look in a bit more depth if you want to. But we know that with strengthening exercise, we do see significant changes in pain and function, but we don't see changes in movement. And we're analysing this data at the moment, and we know that the strength of effect there is better for gait retraining versus strengthening exercise. So I think the message we can give you at the moment is that they both work, but we have a better accepted mechanism behind gait re-education, one of a kinematic change. And because the strength of effect is stronger, you can infer that you will probably get people better quicker, as opposed to just with strengthening exercise. Now, my bias as a physiotherapist has always been towards exercise. I see it as a core skill for our profession, and I don't want this research we're doing at the moment to suggest that strengthening exercise or any exercise, we don't want to get into a linguistics issue, but
absolutely.
I don't want to take away the role of exercise. And my long-term hypothesis for my PhD, my eventual clinical trial, is that gait re-ed and strengthening exercise combined will be more effective than gait re-ed or strengthening exercise in isolation at long-term follow-up. The important disclaimer for all the data we've just mentioned is that it's to short-term follow-up. So short-term follow-up with these sort of proposed neuromuscular adaptations, you can be effective in a very short period of time. To make that effective at a long term in order to achieve a clinical carryover that lasts long beyond when the patient is discharged, and in order to give you a robust runner that can continue to do the distances that they want to do, my bias perhaps and my clinical stance is that you need to do both, and I'm hoping to confirm or refute that hypothesis through my PhD work.
Okay, no, that's great. And I mean, me and you could chat about this all day long. I know we will get you onto a full-length podcast later in the year. That's our intention. But we wanted to try and get this out. We spoke off the microphone last week, and your third point that you fancied raising was the most intriguing to me. I mean, I'm really interested in what we've just already chatted about. But the third point was regarding your stance on where we're at as a profession with regards to paradigm.
Absolutely. And this is a point I have raised a couple of times. I tend to raise it when I teach, and I've certainly had this discussion with a few notable names on social media with regards to the sort of two polarized extremes, if you will, of people who sit firmly in the camp of being a pain scientist and people that sit firmly with regards to thinking about biomechanics and a very structural biomedical model. And I like to view myself, and perhaps this is a little bit of preconceived arrogance, but I like to think I bring those two variables together quite nicely in my clinical practice. And as an experienced clinician and having worked for Pure for a number of years and being comfortable within our sort of clinical management program, I'm happy that the majority of our clinicians that I interact with on a day-to-day basis do integrate pain science, biomechanics, exercise intervention. I like to think, we do a pretty good job here at Pure of bringing those facets together. And I'm a positive guy. I like to think about a glass half full. I like to try and, show people what does work as opposed to spending my time sort of constantly besmirching things that we perceive not to work. I personally think that's a waste of time and it won't advance the profession. But I genuinely do think there has been a positive paradigm shift towards a nice integration of the sort of emerging approach of pain science and the sort of historic approach to movement and biomechanics, which I know from our discussions off the microphone that you perhaps disagree, don't you?
I do. I do to some extent, but I do completely understand and do not question the fact that is. I can understand why you've landed where you have with the people that you work with and the circumstances that you now work within. And I think that's fantastic. And it's something that just makes me want to move down to your neck of the woods, in all honesty. But I think the main reason is because it does contradict every conversation I've had with all the other people, both on the podcast, the other people I've had the privilege of meeting through our work in trying to promote evidence-informed practice, but also particularly off the microphone, or people that I get invited to review courses and chat amongst people and immerse myself in amongst other clinicians. I don't see it having shifted very far at all, and therefore it is something that really interested me, and I think it's still a great point that you raised, but I don't know whether that pendulum has shifted too far. I agree that sometimes the pendulum does swing too far one way or the other. I don't see it settling in the middle with the majority. I would say, though, when it comes to biomechanics, I think I do agree that you sit very nicely in the middle and are willing to discuss with both camps, as we say. But I just thought, when it comes to how biomechanics plays with pain science, the difficulty is that if we start thinking under what is it that's hurting and why is it hurting, that's where it starts to get tricky, and I think that's where people struggle to find the middle ground. So I thought, just for the sake of it, see what you think to this statement I've thrown together. So I did finally write something down. Is biomechanics can sometimes influence nociception, which can sometimes influence pain in some people some of the time. Now, I don't know whether you're going to agree with that or not, but although I agree that the knowledge we need to give everything ample consideration, based on that statement, is it worthy of being a priority when it comes to treating pain? Is it something that needs to be right at the forefront of our mind?
I think it's a topic that very much depends on the population in front of you. But I think that's a fair statement. My sort of 30-second whirlwind summary would, and I say this, I'm teaching my Gait re-education course with my colleague James Dunn tomorrow, and something I often say at the start of that course is that just because pain science is emerging, and that's great, it doesn't mean that biomechanics ceases to exist. And I think we're terrible as a profession for throwing the baby out with the bathwater.
Absolutely, yeah.
a lot of what we do can often be very cyclical, and it's a bit like Converse All-Stars were popular when I was a kid, and now I'm wearing them again 30 years later. We do kind of go through these cycles, and things do become fashionable, and I do, to a point, understand where that comes from, because we all want to do the best by our patients. That's why we're clinicians, and we're designed to help people, and that's what we're trained to do. And I think Greg made a very relevant point in that we don't have to have these wonderfully complicated explanations for what we do. I'm a big advocate of one of Einstein's saying, which is that the smartest people in the room ask the best questions, and the smartest people in the room make complicated things very, very straightforward. It just disappoints me that we have these camps within our profession, and ultimately we're there for the good of the general public. We're there for the best outcome for our patients, and there are going to be different ways that we come to the same end. And something I tell all of my students at the university is that one big covariate that we can't possibly try and stratify for is the natural variation in human anatomy, neurochemistry, biology, etc., etc. We're all slightly different, and we're all going to do slightly different things. It really is a sum of the people, sum of the time situation, and there really are no recipes for patellofemoral pain or for any other pathology, and that's where your clinical reasoning comes in. And that's where, for me, I'll throw another little hand grenade out there. Perhaps you can get there to the other end, but that's why, for me, there is no real substitute for postgraduate education. I feel like my ability to reason and think has really changed as a result of my sort of continued journey through academia, having done a master's degree and now fortunate enough to be in a situation where I can study for a PhD.
And in your opinion, assessed postgraduate study, so something that is more formalised?
That would be I do have a natural bias towards academia. I enjoy it. It's something I've always known I would sort of continue on in, and there will probably be people that are happy to shoot me down and disagree with me, but I do think that formalised, assessed postgraduate study does really refine your clinical reasoning. I'm sure there's people out there that will say you can get there to other ends, and perhaps just lots of good clinicians are constantly immersed within good quality CPD that really makes you think. But if you look at, let's take Greg as an example, because we keep mentioning Greg's done a lot of academia, and I think that's part of the reason why he's able to think on a good level, and also why he comes up with good questions and why he constantly challenges himself.
On Greg's podcast, there wasn't an awful lot of chat about psychosocial variables. He wasn't necessarily going down that route. I mean, would you agree that was a surprise in Greg's podcast? It wasn't massively psychosocial, but it was somewhat pathoneurological rather than sort of pathokinesiology.
Yeah, and I think that the slight difference between Greg and I is that historically Greg's done a lot of spine work, and again, I will hold my hands up and say that I really don't like treating back pain. I'm fortunate enough that I tend to see lots of nice lower limb pathology here. I don't see a huge amount of spinal pain, but I thought it was a good listen. Certainly everyone should give it a listen and see where that sort of stance is coming from. But my sort of gut reaction, as I've said, is that I don't think we do things that differently. And I do feel like certain people who immerse themselves in the pain camp do, to a point, feel like the world is against them, and that they're really sort of ice skating up this big hill that they're never going to get to the top of because all of us academics and clinicians just refuse to listen to them. I don't think that's the case at all. And perhaps it's the benefit of working in London, surrounded by, I'm completely happy with the fact that I'm very fortunate to work for Pure and to be surrounded by such great colleagues, both in my clinical practice and in my academic practice. But I do think it's changing. We will see.
So I really appreciate your time today, and thanks once again for all your thoughts.
My pleasure. Thanks for having me. It's been good fun.
Many thanks to Brad Neal for our first response to an episode. The fact that we set out for a 15-minute snippet and ended with a 35-minute feature-length podcast tells you just how topical this is. I look forward to chatting to Brad further later in the year, partly because, in my opinion, the underlying factor in all of this debate is there seems to be a disparity between what those who feel that biomechanics are more relevant and the likes of Greg who clearly think that they are less relevant, as to what the main driver of symptoms is, sort of the age-old debate between neurology meets tissue physiology, where do they sit within which populations, so I'm sure we'll get a chance to debate that further with Brad, who clearly doesn't see this as being much of a sensitivity issue as much as it is a stress response locally at the tissues. And we'll be back on our usual streams for session 17 very shortly. Bye for now.